Okay, here are the immediate rules of the road for emergency blood. It's pretty straightforward. Give O positive to males and O negative to females. But you also need to know exactly how to spot and manage the fallout of a hemolytic transfusion reaction. An acute reaction happens fast. We're talking before the transfusion even finishes or within 15 minutes of starting it. A delayed reaction, on the other hand, creeps up after 24 hours, but at less than 4 weeks out. Now, if a major reaction hits, your algorithmic management is key. You're going to push fluids and mannitol, pass a Foley catheter to keep that urine output strictly above 100 milliliters per hour, and aggressively alkalinize the urine with sodium bicarbonate.
Here's a crucial, kind of counterintuitive point. Massive transfusions can actually cause bleeding by washing out your clotting factors. We call this dilutional coagulopathy. Officially, it's defined as transfusing blood products greater in volume than a patient's normal total blood volume in under 24 hours. So how do we stop it? That 1:1:1 ratio of packed red cells, platelets, and fresh frozen plasma is your absolute best prevention strategy. But hey, if the coagulopathy has already developed, jumping in with fresh frozen plasma is your direct treatment.
Let's look at how hemorrhage actually progresses physiologically across 4 distinct classes. It's really fascinating how the vital signs and mental state shift. In Class 1, with under 15% blood loss, the patient looks completely normal. Moving to Class 2, hitting that 15 to 30% loss mark, the heart rate jumps over 100, blood pressure becomes orthostatic, and you'll notice the patient getting pretty anxious. Then we hit Class 3, 30 to 40% loss. This is where frank hypotension sets in, the heart rate climbs over 120, and confusion really takes over. Finally, Class 4. This is when blood loss exceeds 40%. We're talking severe hypotension, a heart rate screaming past 140, and the central nervous system basically shutting down, leaving the patient completely obtunded.
Section 2. Surgical shock and decoding its parameters. Because if that hemorrhage isn't controlled quickly, our patient plummets right into our second major clinical challenge.
You can instantly distinguish the 4 major types of shock just by scanning their cardiovascular parameters. Look at septic and neurogenic shock. They're defined by their low vascular resistance. That's a huge contrast to the high resistance we see in hypovolemic and cardiogenic shock, where the body is heavily clamping down. Also, keep an eye on cardiac output. It's uniquely high initially in septic shock before it eventually drops, whereas it's consistently low in all the other forms. Now, while every type of shock shares a high base deficit, you can isolate cardiogenic shock by its distinctly high central venous and pulmonary capillary wedge pressures.
So what happens if you identify neurogenic shock from those parameters? Well, this is your exact, stepwise, algorithmic response. Initially, you have to push fluid. If there's no response to that volume resuscitation, you escalate. You give norepinephrine or phenylephrine. But here's the real kicker. If there's associated bradycardia, which is a classic hallmark of neurogenic shock, dopamine is definitively your drug of choice.
Section 3. Wound healing and the science of recovery. Having stabilized the hemodynamics, our patient survives surgery, which brings us to the local mechanics of tissue recovery.
This biological timeline maps out the exact physiological phases of a healing wound, almost like a biological clock. Days 2 to 3 are the inflammatory phase. From days 3 to 21, the tissue enters the proliferative phase, hitting its maximum collagen content precisely right between days 17 and 21. Following this, from 3 weeks up to 3 months, sometimes even up to 2 years, is the maturation or remodeling phase. Now, immediate maximum tensile strength occurs around day 13 to 17, but it's really vital to remember that the overall maximum tensile strength hits at 12 weeks. And here is a massive exam pearl for you. The tensile strength of a wound never, ever reaches normal again. It maxes out at about 80%.
People frequently confuse these 2 abnormal healing processes, but their boundaries, genetics, and treatments are totally distinct from one another. A hypertrophic scar behaves well enough to stay within the confines of the original wound margins. Your first-line treatment here is simply applying a pressure garment or using pressure massage therapy. A keloid, however, is a completely different beast. It aggressively grows beyond the original wound margins. It actually has an autosomal dominant genetic predisposition, particularly in African Americans, and it won't just spontaneously regress. Notice the unique anatomical predilection too. Keloids absolutely love the triangle formed by the zippy sternum below and the 2 shoulder tips above. First-line treatment for minor keloids is silicone gel sheeting, often combined with intralesional steroid injections, and honestly, that remains the absolute best treatment for major and recurrent keloids too.
Section 4. Infections and sepsis, focusing on surgical complications. Unfortunately, the most common cause of delayed wound healing overall is infection, which drags our patient right into our fourth clinical cluster.
You absolutely have to lock in these bug-to-disease matches. For starters, the most common surgical site infection overall, that's Staph aureus. If your patient develops cellulitis or lymphangitis, characterized by those distinct red streaks running up the limbs, the culprit is Streptococcus pyogenes. Here's a highly testable one: a foul-smelling intra-abdominal abscess carrying a very specific, kind of weird, camembert cheese smell. That is a dead giveaway for a Bacteroides fragilis infection. Ventilator-associated pneumonia is most commonly caused by Pseudomonas aeruginosa. And finally, if a patient presents with mild pseudomembranous colitis, meaning diarrhea without the fever or abdominal pain, your first-line drug is going to be oral metronidazole for 10 days.
Now, if an infection takes hold systemically, we have to be on high alert for systemic inflammatory response syndrome, or SARS. This is officially defined by hitting at least 2 of these specific vital sign or lab thresholds. We're looking for a temperature above 38 degrees Celsius or below 36, a heart rate over 90 beats per minute, a respiratory rate over 20, or a PaCO2 under 32 millimeters of mercury, and finally, a white blood cell count over 12,000, under 4,000, or showing greater than 10% immature neutrophils.
Watch how this dangerous cascade builds. Once you confirm a documented infection alongside those SIS criteria we just talked about, you officially have sepsis. And the very moment hypoperfusion markers show up like lactic acidosis or oliguria indicating the kidneys are starting to slow down, the diagnosis aggressively escalates to severe sepsis. The absolute peak of this cascade is septic shock. This is categorized when you have sepsis and organ dysfunction combined with refractory hypotension. By definition, this means the patient's systolic blood pressure has dropped below 90 millimeters of mercury, or you're requiring active vasopressors just to keep it above that 90 mark. Section 5. Tetanus prophylaxis and wound management. Finally, no matter if our patient suffered a clean surgical incision or a dirty trauma, we have to apply the algorithmic logic of tetanus prophylaxis. So for a clean, incised wound that's fresh, meaning it's under 6 hours old, your decision tree hinges entirely on one thing. Was their last booster inside or outside of a strict 5-year window? If they had a complete toxoid course or a booster in the past 5 years, absolutely nothing is required. You're good to go. If that complete toxoid or booster was more than 5 years ago, you just give 1 dose of tetanus toxoid. But if they've never had a complete course or their immunity status is just completely unknown, you can't take chances. You must give the complete course, administering 3 doses of tetanus toxoid together.
Conversely, for dirty, contaminated, or older wounds that are past that 6-hour mark, the rules shift to provide much more aggressive coverage. If they've had a complete toxoid or booster in the past 5 years, again, nothing is required. But you've got to carefully check if the patient falls into that dangerous gap between 5 and 10 years since their last shot. If it's been more than 5 years but less than 10 years, you are required to give 1 dose of tetanus toxoid immediately to boost their immunity against that highly contaminated field.
All right, we've survived the OR, halted shock in its tracks, navigated tissue healing, and successfully mapped the sepsis cascade. But before we wrap this explainer up, let's test your memory with one last rapid-fire scenario. If a patient with chronic liver disease starts bleeding, do you remember exactly which blood product they require? The golden rule here is to immediately administer fresh frozen plasma.
When we're talking about tetanus prophylaxis, things get very specific based on the wound. If you've got a dirty or contaminated wound that's over 5 hours old and the patient's immunity status is totally unknown, that uniquely requires the whole shebang, the complete toxoid course plus a single dose of tetanus immunoglobulin and prophylactic benzyl penicillin. On the flip side, a clean wound is super straightforward, just a toxoid booster if it's been more than 10 years. Shifting gears to sterilization guidelines, standard autoclaving relies on moist sterilization. We're talking steam under a really high pressure of 15 pounds per square inch, hitting exactly 121 degrees Celsius for at least 15 minutes. But what about heat-sensitive stuff like endoscopes or arthroscopes? You can't autoclave those, so instead we immerse them in 2% glutaraldehyde or 2% peracetic acid to get them properly sterilized.
Now, managing an intestinal obstruction caused by Ascaris worms follows a very strict, step-by-step clinical algorithm. Your absolute first line of action? Administer hypertonic saline. If that does the trick, great. But if it fails to resolve the obstruction, you move to step 2, which is a laparotomy where you actually milk the worms right through the ileocecal valve. And if that still doesn't work, you've got to escalate to step 3, an enterotomy for direct manual worm retrieval.
Let's look at hepatic hydatid cysts. Your go-to first-line test is an ultrasound, but a CT scan is definitely the best overall diagnostic tool you have. Surgically speaking, complete excision is the most common treatment. Though pair therapy, which stands for puncture, aspiration, injection, and reaspiration, is becoming a really solid option for cysts larger than 5 centimeters. Now let's talk materials. We divide our sutures into absorbable types, think catgut, Vicryl, and PDS, and non-absorbable ones like silk, surgical steel, and Prolene. Keep in mind, surgical steel and staplers are incredibly resistant to infection. When you're closing a midline abdominal incision, the preferred method is a mass closure using continuous PDS. But here is a huge caveat. That specific midline incision actually carries the highest rate of post-operative respiratory complications, like atelectasis. Finally, for intestinal anastomoses, the absolute best technique right now is a single-layer extramucosal closure. Just make sure the needle moves from the inside to the outside on the downstream edge, because that prevents you from creating a dangerous intimal flap. You know, positioning and physical mechanics in the operating room matter immensely. Take the ulnar nerve, for example. Because of compression right at the medial epicondyle, it is the single most commonly damaged nerve during both general anesthesia and axillary nerve blocks. And shifting over to laparoscopy, you might be surprised to hear that the most common injury from diathermy use is actually burns. Also, when you're doing a standard 4-port laparoscopic cholecystectomy, your angles need to be incredibly precise. We are talking about a manipulation angle of exactly 60 degrees, an elevation angle of 30 degrees, and an azimuth angle of 30 degrees. All of this happens while the patient is set up in a reverse Trendelenburg position with a left tilt. In pediatric gastrointestinal surgery, the diagnostic signs are classic, textbook, and honestly highly testable. An annular pancreas is going to show that famous double bubble sign on imaging, and you treat it with a duodeno-duodenostomy. Then you have congenital hypertrophic pyloric stenosis. This presents with non-bilious vomiting, a very distinct olive-like mass in the epigastrium, and paradoxical aciduria. The fix there is a Ramstad pyloromyotomy. For intussusception, you're looking for a positive dance sign along with those red currant jelly stools, which you'll confirm with an abdominal ultrasound. What about esophageal atresia with a tracheoesophageal fistula? You confirm that when a nasogastric tube just stops right at the upper pouch on a chest x-ray, all while you can clearly see gas in the abdomen. Lastly, for biliary atresia, timing is literally everything. A Kasai portoenterostomy has to be done before the 8-week mark. If they are older than 8 weeks, a liver transplant becomes the required intervention. Getting the timing right for pediatric surgeries is an absolute must-know clinical pearl. For instance, an orchidopexy for a palpable undescended testis is currently recommended right between 6 to 12 months of age. Hypospadias? That should be repaired before they hit 2 years old. A hydrocele is a bit different. We hold off and repair those only after 3 years. Umbilical and supraumbilical hernias are typically repaired around 4 years of age, assuming they haven't just closed up on their own by then. Epigastric hernias, on the other hand, don't have a strict age cutoff. You repair them exactly when they become symptomatic. Oh, and definitely keep this memorized for the wards. The absolute most common type of pediatric growth plate fracture is a Salter-Harris type 2. When we compare pediatric abdominal masses, we get some really clear clinical distinctions. Take a Wilms tumor, or nephroblastoma, for example. This typically shows up as an incidentally discovered mass in a young, completely healthy-looking child who happens to have hypertension and renin in their blood. You treat that with a surgical resection, specifically a radical nephrourectomy, followed up by chemotherapy or radiotherapy. But in stark contrast, a neuroblastoma presents in a very toxic-looking, unwell child. The palpable mass here usually crosses the midline, and you'll see hypertension along with catecholamines in the urine. For neuroblastoma, the management is a palliative surgical resection combined with chemotherapy. Let's look at pediatric orthopedics and some critical diagnostics. Developmental dysplasia of the hip, or DDH, is a big one. In unilateral cases, you'll see a limp or tiptoeing. But in bilateral cases, it's more of a waddling gait with lumbar lordosis. To screen at-risk babies for DDH, ultrasound is your investigation of choice at 6 weeks. Once they pass 4 months, you switch to x-rays. Now, what about a flat foot? The initial management there is always going to be an orthosis. And if you're looking at syndactyly, the most common location by far is the third web space, right between the middle and ring fingers. Back to the GU tract for a second, if an undescended testis is non-palpable, a laparoscopy is the absolute best diagnostic test to locate it. But if it is palpable right there in the inguinal kennel, you do a standard Dartow's pouch orchidopexy. Pivoting down to the lower GI tract, a rectal biopsy remains the absolute gold standard investigation to diagnose Hirschsprung disease. You just can't beat it. Understanding radiological parameters is absolutely crucial for imaging and oncology. Some tumors are highly radiosensitive. Think seminoma, lymphoma, and cancers of the lung, breast, and prostate. On the flip side, things like malignant melanoma, thyroid carcinoma, renal cell carcinoma, and gastric adenocarcinoma are highly radioresistant. Radiation just doesn't work well on them.
Just to quickly clarify a couple of epidemiological terms while we're here, incidence only refers to the number of newly diagnosed cases, while prevalence is the whole pie, both old and new cases together. When it comes to imaging, MRIs have some hard, absolute contraindications. We're talking ocular metallic foreign bodies, pacemakers, cochlear implants, and intracranial aneurysmal clips. No exceptions there. But there are also relative contraindications like severe claustrophobia or being in the first trimester of pregnancy.
To really minimize perioperative risks, stopping certain medications has to follow a very strict schedule. For instance, smoking needs to stop a full 8 weeks prior to surgery to actually get the maximum beneficial effect on pulmonary compliance. Estrogen-containing pills or hormone replacement therapy, those must stop 4 weeks before surgery. As we get closer to the big day, clopidogrel is stopped at the 10-day mark, aspirin at 7 days, and warfarin at 5 days. All other NSAIDs, aside from aspirin, should be stopped about 3 to 4 days before they hit the operating table. Once we're even closer to the operating room, the rules shift a bit. Lithium needs to be stopped 24 hours before surgery, and you always check those blood levels for toxicity. Low molecular weight heparin is stopped exactly 2 hours before, while the newer oral anticoagulants, like rivaroxaban, need to be stopped 2 to 3 days prior. For diabetes management, stop sulfonylureas and metformin 1 to 2 days before, and transition your patient to a sliding scale of insulin. MAOIs must be stopped at least 2 weeks before, and tricyclic antidepressants need to go as well because they interact poorly with anesthesia. Now that being said, crucial medications like anticonvulsants, anti-Parkinson's meds, and statins absolutely must be continued perioperatively. Don't stop those. For most surgeries, you want to aim for an INR of 1.5 or less, and fasting instructions are non-negotiable. 2 hours for clear fluids, 4 hours for breast milk, and 6 hours for any solid food.
A huge part of preoperative physiological optimization comes down to timing. Imagine an infant with a congenital diaphragmatic hernia who is totally unstable with respiratory complications. They need mechanical ventilation or ECMO first. The actual surgical repair has to be delayed until 24 to 48 hours later. Now, what about fresh frozen plasma? It has to be given directly on the day of surgery because its half-life is incredibly short, just 4 to 6 hours. For patients with cardiac disease, beta blockers should definitely be continued right through surgery to actively decrease their mortality risk. But if a patient has had a myocardial infarction, any elective surgery must be postponed for exactly 6 months, no exceptions. Finally, if you've got a patient who requires nutritional support, you have to provide it for a minimum of 2 weeks before surgery for it to have any real measurable impact on their morbidity. In anesthesia management, there are some very strict warnings you have to heed. Nitrous oxide, it has to be avoided during general anesthesia because it accumulates dangerously in air-filled cavities, and bupivacaine is absolutely never used for a Beer's block. If your patient suddenly spikes a high-grade fever, starts shivering, and has dark urine, you need to suspect malignant hyperthermia immediately. You literally stop the surgery, hyperventilate them with 100% oxygen, push IV dantrolene, and alkalinize their urine. For ARDS, intubation with positive end expiratory pressure, or PEEP, is your best management strategy. When dosing lignocaine, precision is key. It's exactly 3 milligrams per kilogram without adrenaline and 7 milligrams per kilogram with adrenaline. Be really careful with pulse oximetry too, because it'll give you false readings if there's carbon monoxide poisoning, methemoglobinemia, nail polish, IV dyes, or deeply pigmented skin. Ketamine is another tricky one. It is strictly contraindicated in neurosurgical patients and anyone with diabetic autonomic neuropathy. And just a fun fact to keep in your back pocket, endorphins are our body's endogenous pain relief, and tetracaine is the longest-acting anesthesia we have. When we're managing postoperative complications, there are some very specific interventions you need to know. A lumbar sympathectomy is used specifically to treat rest pain and clinical limb ischemia. If you've got a dehydrated patient presenting with anuria, the resulting electrolyte abnormality you're going to see is hyperkalemia. Want the simplest, most accurate measure of a person's nutritional status? It's just their body weight. Severe hyponatremia, or SIADH, has to be managed with a very slow infusion of 3% hypertonic saline until those neurologic symptoms resolve. After an esophagectomy, a patient is going to experience a massive nitrogen loss. We're talking about 90 grams per day. For patients queued up for major upper GI surgery because of a corrosive stricture of the esophagus, a jejunostomy is the most appropriate route of nutrition. And lastly, if a patient starts seizing during a transurethral resection of the prostate, you have to suspect dilutional hyponatremia immediately. You can prevent this by using a 1.5% glycine continuous flow, non-hemolytic irrigating solution when using monopolar resectoscopes or just standard saline if you're using bipolar resectoscopes.
Now, when you're administering total parenteral nutrition, or TPN, the primary source of fatty acids is actually sunflower oil. If a patient on TPN happens to develop sepsis, watch out, because glucose intolerance is the very earliest clinical sign you'll see. On the other hand, a complete lack of lipids in their TPN will directly cause skin rashes and hair loss. Broadly speaking, common complications of TPN include fluid overload, hyperglycemia, and liver function abnormalities paired with vitamin deficiencies. Looking at broader fluid and metabolic issues, hypokalemia is heavily associated with diarrhea. Most of the nitrogen loss we see after a major trauma actually happens due to the severe breakdown of skeletal muscles. We also have to account for daily and sensible water loss, which typically ranges from 600 to 900 milliliters a day. And when you're calculating standard surgical maintenance fluid, it rigorously follows a set formula. 100 milliliters per kilogram per day for the first 10 kilograms, 50 milliliters per kilogram per day for the next 10 kilograms, and 20 milliliters per kilogram per day for every subsequent 10 kilograms. In acid-base physiology, it's all about noticing exactly how the body compensates. It's actually a pretty elegant system. Metabolic disturbances always trigger immediate respiratory compensation. So metabolic acidosis causes immediate hyperventilation, while metabolic alkalosis causes immediate hypoventilation. It's an instant respiratory fix. Conversely, respiratory disturbances rely entirely on delayed renal mechanisms. Respiratory acidosis leads to delayed renal bicarbonate reabsorption, and respiratory alkalosis leads to delayed renal bicarbonate excretion. The kidneys just take a lot more time to kick in. Early signs of sepsis are critical to catch. Physically, they manifest as a changing mental status, tachypnea, which leads straight to respiratory alkalosis, and flushed skin secondary to massive peripheral vasodilation. You should also suspect occult sepsis if a patient has intermittent hypotension and requires continuous fluid resuscitation just to maintain their urine output. When you're dealing with any acid-based disorder, remember, the core management is always to treat the underlying cause. And notably, metabolic alkalosis is strongly associated with hypokalemia. Moving on to infections, the absolute most common cause of catheter-related bloodstream infections in a central venous line is coagulus-negative staphylococcus, specifically Staphylococcus epidermidis or albus. Finally, keep this huge physiological shift in mind. The basal resting metabolic rate shoots up by a massive 50% during a state of sepsis. So starting with postoperative fluids, point 144 lays it out clearly. Your go-to maintenance fluid is strictly 5% dextrose in water with lactated ringer. Moving right into nutrition, points 145 through 147 highlight just how dynamic the basal metabolic rate really is. A stable patient needs about 20 to 30 kilocalories per kilogram per day. But watch what happens during starvation. That drops down to 15 to 20. On the flip side, in severe trauma or sepsis, it skyrockets up to 40. Now, anatomically speaking for point 148, it's pretty amazing, but you can actually resect up to 50% of the gut without causing any severe metabolic abnormalities. For patients with severe malnutrition, point 149 targets 30 kilocalories per kilogram per day. And you really need to keep point 150 in mind. The absolute first sign of fluid overload in patients on total parenteral nutrition, it's simply weight gain.
Let's translate those metabolic demands directly into clinical presentations. Looking at GI issues, point 151 tells us that prolonged emesis, like what you'd see in hypertrophic pyloric stenosis, requires 0.9% normal saline with potassium chloride, which naturally leads into point 152. The most common cause of hypokalemia is, you guessed it, vomiting and diarrhea. Shifting gears to post-surgical complications, point 153 is a classic example. Post-thyroidectomy, tingling and muscle cramps point straight to hypocalcemia. You're going to need a continuous infusion of calcium gluconate for that. For respiratory distress, points 154 and 155 show that it's the most common symptom of a pulmonary embolism, with tachypnea being the key sign. And remember, the CT pulmonary angiogram is your gold standard diagnostic test here. Now, if that respiratory distress pops up just hours after a thyroidectomy, point 157 warns that you're likely dealing with a tension hematoma. You have to do an immediate wound exploration. But if the distress happens immediately post-extubation after removing a huge goiter, point 158 says that's trichomalacia. Finally, point 159 dictates that if a patient has hoarseness without respiratory difficulty after a thyroidectomy, you're looking at recurrent laryngeal nerve palsy.
Moving on to critical interventions. Point 156 establishes some very precise numerical triggers for transfusions. You absolutely must transfuse blood if the hemoglobin drops below 6 grams per deciliter. Or if it's sitting between 6 and 8, you transfuse if you anticipate surgical blood loss. When we look at vascular threats, points 160 and 161 cover DVTs and embolisms. The most alarming symptoms that predict adverse outcomes in an acute pulmonary embolism are an altered mental state and cardiogenic shock. For diagnosing a DVT, duplex ultrasound is your go-to investigation. And speaking of an altered mental state, point 162 makes it clear. Altered mental status is actually the absolute most common indication for endotracheal intubation.
Now, post-operative timelines are strictly mapped out in points 163 and 164. If you see a fever in the first 24 to 48 hours, it strongly implies atelectasis or a wound infection. You're thinking streptococci or Clostridia here. But if it's after 72 hours, your suspicion really needs to shift to suppurative issues, deep surgical site infections, DVTs, or UTIs. In the context of trauma, point 165 notes that acute gastric dilation classically presents as vomiting. Now, for deceleration trauma, points 166 and 167 give us some classic patterns. Seatbelt or lap belt injuries often cause covert injuries like duodenal ruptures and chance fractures of the lumbar spine. Mesenteric avulsion is another classic deceleration injury. When it comes to hemorrhage control, point 168 is a non-negotiable management step. The very first thing you do for wound bleeding is packing and applying pressure. And point 169 is a strict anatomical rule for pelvic binders. You have to apply them exactly at the level of the greater trochanters. And here's the kicker: do not remove them, not even during an emergency laparotomy.
Getting into shock and stabilization, point 170, is a quick reminder that hypovolemic shock is by far the most common type you'll encounter in trauma. To manage that volume loss, point 171 lays down the strict limits for tourniquets. You need to deflate them after 1 hour for just a few minutes. The absolute maximum upper limit is 1.5 hours. Pressure cutoffs are exactly 100 millimeters of mercury for the upper limb and 150 for the lower limb. Now, during resuscitation, point 173 dictates how we handle the airway and suspected C-spine injuries. You keep it patent strictly using the jaw thrust maneuver. Absolutely avoid the head tilt chin lift. Neurologically, point 174 establishes our baseline parameters. Normal cerebral perfusion pressure, or CPP, is 75 to 105 millimeters of mercury. Mean arterial pressure is 90 to 110, and intracranial pressure is 5 to 15. If that ICP starts rising significantly, point 176 tells you to immediately look for Cushing's triad, which is bradycardia, hypertension, and irregular respiration.
Point 172 breaks down the latest CPR guidelines. There's major commonality here to point out. No matter the patient's age, the compression rate is universally 100 to 120 per minute. For adults over 8 years old, the ratio is always 30 to 2, whether you've got 1 or 2 rescuers on scene. However, for children aged 1 to 8 and infants under 1, that ratio shifts depending on your team size. A single rescuer still uses the standard 30 to 2 ratio, but if you have a 2 rescuer team, you switch that up to a 15 to 2 ratio.
Points 175, 177, and 181 give us a really critical comparison between extradural and subdural hematomas. Extradural, also known as epidural hematomas, are caused by a rupture of the middle meningeal artery. Clinically, the patient is going to experience that classic lucid interval. When you get the CT scan, you'll see a biconvex, lens-shaped hyperdense mass. Treatment-wise, you have to do a burr hole if there's a midline shift greater than 1.5 centimeters or a craniotomy for definitive management. On the other hand, subdural hematomas come from the rupture of bridging cerebral veins. For an acute subdural, a craniotomy is required, but if it's a chronic subdural hematoma, you manage that with a simple burr hole.
Point 179 demands absolute precision with the Glasgow Coma Scale. Let's break it down. Best eye response is scored out of 4. Spontaneous opening gets a 4. To speech is a 3. To pain is a 2. And no opening is a 1. Best verbal response is out of 5. A perfect 5 means they are oriented. Then it scales down through confused at 4, inappropriate words at 3, incomprehensible sounds at 2, all the way to 1 for no verbal response. Finally, best motor response is out of 6. Obeying commands gets a 6, localizing pain is a 5, withdrawing from pain is 4, flexion to pain is 3, extension to pain is 2, and again a 1 means no motor response at all.
Continuing with neurotrauma, point 178 outlines the clinical timeline for raised intracranial pressure, specifically when it hits between 20 and 25 millimeters of mercury. It sequentially presents first as a change in consciousness, that's followed by ipsilateral pupillary dilation, then irregular respiration, bradycardia, and finally hypertension. To acutely reduce that raised ICP, point 180 gives us the exact management steps: endotracheal intubation, hyperventilation, mannitol infusion, and head elevation. But be careful, you must strictly avoid mannitol if the patient is hypotensive.
Regarding the skull itself, point 182 lists the definitive surgical indications for fractures. You absolutely must intervene surgically for depressed fractures greater than 1 centimeter, dural tears, CSF leaks, intracranial hematomas, frontal sinus involvement, or any gross contamination.
Moving down to the face and neck, point 183 points out that Battle's sign indicates a fracture of the base of the skull or the middle cranial fossa. For cervical injuries, point 184 explains the mechanics of whiplash. It happens due to sudden movement that goes way beyond the normal range of hyperflexion and hyperextension. Points 185 through 187 highlight some really good facial exam pearls. The nose is the most common site for a facial fracture. Human bites are exceptionally dangerous because they introduce a nasty mix of both anaerobes and aerobes. And the condyle neck is the most commonly fractured site on the mandible. Lastly, for this section, point 188 specifically states that a traumatic transection of the parotid duct must be repaired over a cannula, and you have to do this under strict loop magnification.
Shifting focus to the primary survey in thoracic trauma, point 189 categorizes immediately life-threatening injuries. These are your airway obstructions, open pneumothoraxes, tension pneumothoraxes, massive hemothoraxes, flail chests, and pericardial tamponades. Point 190 contrasts those with potentially life-threatening injuries, which include esophageal and tracheobronchial injuries, pulmonary or myocardial contusions, and ruptures of the diaphragm or aorta. For immediate management on the field, point 191 dictates that a hissing chest wound has to be covered initially with a 3-sided occlusive dressing. And point 192 has a critical warning. If you see a bruise or seatbelt sign on the chest and the patient has normal breath sounds but unstable vitals, that highly suggests an aortic disruption. You need to get definitive confirmation of that via a CT scan.
Points 193 and 194 give us the exact management steps for decompression. Cardiac tamponade is clinically identified by Beck's triad. That's raised jugular venous pressure, muffled heart sounds, and hypotension. To manage it, you need to create a subxiphoid window or perform pericardiocentesis. Now, a tension pneumothorax presents quite differently. You'll see increasing restlessness, tachypnea, absent breath sounds over the effective lung, decreasing oxygen saturation, distended neck veins, and tracheal deviation. The operative procedure here requires immediate needle decompression right in the second intercostal space at the midclavicular line. After that, you follow up with a definitive chest tube placed in the 5th intercostal space at the anterior axillary line.
Looking at point 195, we focus on flail chest. This is characterized by that paradoxical movement. A segment of the chest moves inward during inspiration and outward during expiration. The gold standard diagnostic investigation here is a CT scan. Initial management is actually non-surgical. It requires robust analgesia like IV meds or nerve blocks and high flow oxygen. However, point 196 lists the strict volume indications for an urgent thoracotomy. You have to go in if there's an immediate drainage of 1,500 milliliters of blood, or if it's greater than 200 milliliters consecutively over 3 to 4 hours. It's also indicated for 100 milliliters consecutively for 8 hours, or 120 milliliters consecutively for just 15 minutes. When you do have to perform this, point 209 adds that the most common operative approach for a resuscitative thoracotomy is the anterolateral thoracotomy.
Abdominal stab wounds require some very precise decision-making based on patient stability and the location of the wound. Point 197 says that for a stab wound to the left hypochondrium in a stable patient, you want to perform a laparoscopy just to rule out any visceral or diaphragmatic injury. But point 198 states a full laparotomy is indicated if there's unexplained hypotension or if there's evisceration of abdominal contents, excluding the omentum, combined with peritonitis. In contrast, point 199 clarifies that anterior abdomen stabs that do not reach the posterior rectus sheath require only admission and clinical observation. You only progress to a laparotomy if peritonitis develops. Point 200 notes that if you just have evisceration of the omentum in an otherwise stable patient, that requires a diagnostic laparoscopy. And this is a massive exam pearl in point 201. Absolutely do not perform local wound exploration for hypochondrium injuries. The risk of causing an iatrogenic pneumothorax is just too high.
Continuing with penetrating trauma, point 202 emphasizes that in junctional zones like the hypochondrium, laparoscopy is actually the preferred diagnostic modality over a CT scan. Point 203 gets really specific with upper thoracic stabs based strictly on lateral anatomy. A stab injury in the second intercostal space on the right side immediately threatens the superior vena cava, the right pulmonary artery, or the aorta. Conversely, if that exact same stab injury is in the second intercostal space on the left side, it threatens the pulmonary trunk, the left pulmonary artery, the left atrium, or the aorta.
Looking at some specific trauma complications,
Point 204 observes that if you have torso trauma showing an air fluid level in the left upper chest, along with NG tube coiling, that strongly suggests an acute diaphragmatic rupture. The operative management for that requires repair with Proline 1.0. For hollow viscous injuries, point 205 says you confirm an esophageal perforation using an esophagiogram with water-soluble contrast. Meanwhile, point 206 states that if trauma causes subcutaneous or mediastinal emphysema combined with hemoptysis or a pneumothorax, you should suspect a tracheobronchial injury. In obstetric trauma, point 207 mandates that you nurse a pregnant patient with blunt abdominal trauma strictly in the supine left lateral position. And point 208 identifies the most dreadful complication after a stab injury to the neck that requires urgent surgical exploration, which is an expanding hematoma.
Finally, points 210 and 211 detail our protocols for blunt abdominal trauma. While the spleen is statistically the most commonly damaged viscera, a bruise on the right side or right hypochondrium strongly implies a liver injury. For management, if your initial perihepatic packing fails to control the bleeding, you need to perform Pringle's maneuver. That means clamping the hepatoduodenal ligament for 15 minutes, followed by a 5-minute release. If the bleeding persists even during this maneuver, you have to suspect an injury to the inferior vena cava or the retrohepatic veins. When you're doing the actual liver repair, you only suture active bleeding on liver parenchymal lacerations. You use blunt-tipped, zero-chromic catgut, utilizing continuous sutures for superficial lacerations and horizontal mattress sutures for the deeper ones.
You know that sorting trauma patients requires strict adherence to priority colors, right? We're talking priority I and red for immediate threats, yellow for priority 2, green for priority 3, all the way down to priority 0 and black for those beyond medical salvation. And right alongside triage, we've got to accurately classify blast injuries. It's a 3-stage system. Primary damage stems directly from the blast wave itself hitting the body. Secondary damage happens when objects get propelled by the blast and strike the patient. And tertiary damage is literally when the persons themselves are propelled into solid objects.
Moving on to severe systemic complications, let's look at crush syndrome. You've really got to watch for decreased urine output that's unusually dark in color. And here is the crucial timeline. If the time since the crush injury is greater than 12 hours, you absolutely must proceed to a fasciotomy, or potentially even an amputation. On the flip side, we have gas gangrene. This is caused by Clostridium perfringens and presents with escalating pain, hemorrhagic bullae, and this very distinct sweet-smelling serous sanguinis discharge. For management, you've got to hit it hard and fast. Immediate large-volume resuscitation, triple IV antibiotics including penicillin G, clindamycin, and a third-generation cephalosporin, all paired with aggressive, wide surgical debridement.
Okay, so following long bone fractures, especially of the femur shaft, or after intramedullary reaming, you must watch closely for a fat embolism. GERD's criteria is your diagnostic gold standard here. It hinges on 3 things: observing petechia within a 12 to 72-hour window, severe hypoxemia with a PaO2 of less than 60 millimeters of mercury, and central nervous system depression that is just completely out of proportion to that hypoxemia. You'll also often see pulmonary edema. Now, because fat is actually found in the urine of these patients, the treatment is entirely supportive. It heavily relies on mechanical ventilation, utilizing high levels of PEEP.
Moving right along to torso and abdominal trauma. For abdominal compartment syndrome, burn this number into your brain: the strict 35 millimeter mercury threshold. If intra-abdominal pressure stays above 35, urgent surgical decompression is non-negotiable to counteract the syndrome. Now, post-operatively, if a patient ever reports a popping sensation or if you spot pink serous sanguinis discharge, immediately suspect a burst abdomen or wound dehiscence. And look, when wound edges simply cannot be safely reapproximated, you apply tension sutures or use techniques like a Bogota bag or a sandwich vacuum dressing. This protects the viscera until the edema finally settles down.
When dealing with solid organ trauma, the management indications are super strict. Take the spleen. If the patient is hemodynamically stable, manage it conservatively. But if they're unstable and you see a blush on the CT scan, go directly to angioembolization. With the pancreas, blunt trauma is actually the most common injury mechanism. And here's an example. Major duct injuries to the right of the mesenteric vessels dictate immediate closed drainage. Finally, while over 90% of blunt renal trauma is managed conservatively, if you notice a halo around the kidney on an X-ray, that mandates an immediate high suspicion for a duodenal rupture. Don't miss that.
So, what happens with hemodynamically unstable blunt torso trauma where you suspect pelvic fractures? Your initial move has to be highly specific. Always suspect associated damage to the membranous urethra. Next step, immediately apply a pelvic binder. From there, systematically use the FAST exam. If that FAST is positive, you are heading straight to surgical exploration. But if it's negative, then you're looking at external fixator application and extraperitoneal packing to get that venous plexus bleeding under control.
You know that whole body CT is the gold standard for blunt abdominal trauma, but certain presentations mean you bypass the scanner entirely. For instance, you must always surgically explore a Zone 1 retroperitoneal hematoma. And an anterior abdominal gunshot wound? Mandatory exploration, no questions asked. Now, if you encounter limb trauma presenting with hard signs of ischemia, we're talking pallor and pulselessness, and there's a gap between the vessel ends, a reverse saphenous vein autogenous graft is always preferred over prosthetic materials. Plus, you absolutely have to perform a prophylactic fasciotomy after the vascular repair to prevent compartment syndrome.
Shifting gears now to upper extremity fractures.
When you're looking at classic forearm fracture dislocations, you've got to memorize the exact anatomical targets to tell them apart. It's like a puzzle. A Galazzi fracture isolates the break at the diaphysis of the distal radius, and it's paired with a dislocation of the distal radio-ulnar joint. Conversely, a Monteggia fracture breaks the proximal ulna, and that comes accompanied by an anterior dislocation of the radial head.
Moving further down into the wrist, the exact mechanism of injury dictates the resulting deformity. Both of these involve fractures of the distal 2.5 centimeters of the radius. But here's the difference. A fall onto a hyperextended, pronated wrist gives you the dorsal displacement of a Colles fracture. You'll recognize this clinically by the classic dinner fork deformity. Alternatively, a fall onto a flexed wrist creates a volar displacement, resulting in the Smith fracture, which has that distinct garden spade appearance.
Let's talk about the scaphoid fracture, which hides a really dangerous complication, a huge risk of avascular necrosis. That's because the proximal pole relies on a retrograde blood supply. So, if a patient comes in with trauma and pinpoint pain right in the anatomical snuff box, get x-rays. If the x-rays are negative, but your clinical suspicion is still high, do not send them home empty-handed. You need to apply a thumb spica cast and then reevaluate them in 10 to 14 days. If the diagnosis is still inconclusive after they've been in the cast, immediately order an MRI. It is by far the most sensitive investigation to rule this out.
Navigating complications in the upper limb requires some really precise anatomical knowledge. For clavicular fractures, non-operative management is totally the standard. Surgery is an absolute indication only for open fractures or if there's severe skin tenting. With shoulders, anterior dislocations are the most common, and they're frequently complicated by Bankart lesions and Hill-Sachs deformities. Finally, pay really close attention to exactly where the radial nerve is injured. Damage up in the axilla causes both wrist drop and a loss of elbow extension. But if the nerve is damaged lower down in the radial groove, you'll still get the wrist drop, but elbow extension will remain completely normal.
Down to the lower extremity and knee.
For intracapsular femoral neck fractures, your management algorithm shifts dramatically based on the patient's age, fracture displacement, and baseline mobility. Notice that non-displaced fractures typically just receive fixation, and that goes across all age groups. However, for displaced fractures in patients over 60, we pivot entirely to arthroplasty. If the patient is independently mobile, a total hip arthroplasty is indicated. But if their mobility is limited or they've got major comorbidities, a unipolar hemiarthroplasty, usually an Austin Moore prosthesis, is your definitive choice.
The stakes for these femoral neck fractures are incredibly high. Displaced fractures, categorized as Gardner type 3 and 4, see a massive spike in avascular necrosis risk. It jumps to 30% compared to just 10% in non-displaced fractures. Non-union rates similarly skyrocket, going from 5% up to a staggering 25% with displacement. And hey, if the fracture is in the femur shaft instead of the neck, be acutely aware that up to 2 liters of occult blood loss can literally hide in the thigh without obvious swelling. These patients often present with a shortened, externally rotated limb.
Listen, a knee dislocation is not just a joint injury, it's an absolute orthopedic emergency because of the incredibly high chance of damage to the popliteal vessels. You must immediately examine the distal pulses, specifically checking the posterior tibial and dorsalis pedis. Then, perform an immediate reduction. If the pulse returns right after reduction, you admit them for observation. But if the pulse does not return, or if you detect subtle signs of vessel injury, like an ankle brachial index dropping below 0.9, you must order an urgent CT angiogram to map out that arterial damage.
Jumping back to the femur shaft, the management scales meticulously with age and skeletal maturity. For infants aged 0 to 18 months, we use gallows traction. From 18 months up to 4 years, it's immediate traction followed by a hip spica cast. For kids aged 4 to 12, they're treated with elastic intramedullary nailing. And anyone 12 years and older receives rigid intramedullary fixation. Keep in mind, strict weight limits apply here. You have a maximum of 5 kilograms for lower limb skin traction, and you can go up to 20 kilograms for skeletal traction.
Lastly, let's cover pediatric and open classifications.
The Salter classification is absolutely crucial because it strictly maps the risk of subsequent deformity to the pediatric growth plate. Type 1 sometimes affects growth, while Type 2 is the most common one you'll see overall. The risk severity really climbs sharply at Type 3, which commonly causes abnormal growth, and it peaks at Type 4, which carries a phenomenally high chance of abnormal bone development, meaning it requires perfect anatomical reduction.
When it comes to surgical planning and flap coverage for open fractures, you're relying entirely on the Gustillo and Anderson system. We start down at Type I for low-energy, clean wounds under 1 centimeter, and we progress up to the Type 3 high-energy categories. The critical distinction to remember lies in the Type 3 subgroups. Type 3A has adequate soft tissue cover. Type 3B involves inadequate cover, meaning it requires flaps. And Type 3C is the most severe. That's an open fracture complicated by an arterial injury that dictates immediate vascular repair.
Wrapping up our surgical review, here is a massive clinical warning you can't afford to ignore. If you see a pediatric patient with a supracondylar fracture of the humerus who presents with a white, pulseless hand, immediate closed reduction and percutaneous pinning is your only defense. If perfusion doesn't improve immediately after that, surgical exploration and vascular repair are instantly required. Otherwise, Volkmann ischemic contracture will permanently destroy that limb.
Confidence. It's honestly fascinating how specific physical signs map directly to nerve injuries. Like if a patient can't flex their lateral 3 digits and they've lost sensation in their thumb and index finger, boom. That functional loss is the puzzle piece pointing straight to a median nerve injury. On the flip side, ulnar nerve damage shows up as a loss of flexion and abduction in the ring and little fingers, usually with some ulnar deviation. Now moving up the arm, a lower brachioplexus injury at C8 to T1 results in Klumpsky's paralysis, which classically looks like a claw hand. For entrapment neuropathies, you're definitely going to suspect carpal tunnel syndrome if a patient mentions their nighttime pain is relieved simply by shaking their hand. You'd then confirm that with Tinel, Phelan, and Durkin tests. And finally, if you suspect thoracic outlet obstruction, the Adson's test is your go-to maneuver.
Now, what's really interesting here is how we classified the severity of these nerve injuries using the Seddon classification. The differences in recovery potential are huge. On the milder end, we have neuropraxia. The nerve sheath is totally intact, there's zero Wallerian degeneration, and honestly, the recovery potential is very good. We contrast that with axonotmesis and neurototmesis. In axonotmesis, the sheath is actually still intact, but you do get Wallerian degeneration distal to the injury. Surprisingly, though, the recovery potential still remains pretty good. But neurototmesis, that's your absolute worst-case scenario. We're talking a complete division of the nerve, the sheath, and the fibers. Without surgical intervention, the outcome here is pretty much invariably poor.
Okay, moving on to bone pathologies, the radiographic signs are our biggest clues. An onion skin look on an X-ray, paired with a CD99 positive biopsy, points straight to Ewing sarcoma, which gets treated with neoadjuvant chemo and a wide excision. If you see a sunburst appearance with a Codman triangle, you gotta think osteosarcoma. And definitely remember, its most common site of metastasis is the lungs. Now, for adults over 60 coming in with back pain, always consider multiple myeloma. It's the most common primary bone tumor in that demographic. Another classic presentation you'll see is a patient with dull, aching nighttime bone pain that shows a central nidus on an X-ray. If popping an aspirin or NSAID gives them immediate relief, you've solved the case. It's an osteoid osteoma. Finally, for osteomyelitis, the most common pathogen is Staph aureus, and your absolute antibiotic of choice is amoxicillin with comoxiclav.
Ward 2, skin malignancies and cysts. Let's transition right to the surface of the integumentary system. Surgery requires exact precision, right? And our clearance margins are dictated by strict mathematical matrices based directly on lesion thickness and type. For a standard basal cell carcinoma between 2 and 15 millimeters, you need a 4 millimeter margin. But if it's over 2 centimeters, that margin jumps up to 10 millimeters. Squamous cell carcinoma margins, on the other hand, depend directly on thickness. Less than 1 millimeter thick, that's a 1 centimeter margin.
1 to 4 millimeters needs a 2 centimeter margin, and anything over 4 millimeters needs 2 to 3 centimeters of clearance. For in situ lesions, melanoma in situ gets a 5 millimeter margin, while SCC in situ, or Bowen's disease, gets 4 millimeters. These exact measurements dictate your entire surgical plan.
Beyond margins, complex lesions require super specific techniques. High-risk BCCs, so anything over 2 centimeters, recurrent or located on the inner canthus, are best treated with Mohs microsurgery. For facial reconstruction, a glabellar flap perfectly covers inner canthus defects, while a bilobed flap is exactly what you want for the tip of the nose. Shifting gears to lumps and cysts, pediatric presentations can be incredibly distinct. Picture a brilliantly translucent, fluctuant swelling in the posterior triangle of an infant's neck. That's a cystic hydroma, commonly seen in Turner syndrome. But if you aspirate a neck mass and get yellow fluid packed with cholesterol crystals, that's a branchial cyst. Meanwhile, dermoid cysts have a totally different origin story. They can be congenital along embryonic fusion lines or acquired via trauma. You might know that one as a Taylor's cyst. And finally, when you're evaluating melanomas, keep in mind that superficial spreading is by far the most common macroscopic variant, making up about 70% of cases.
Ward 3. Burn management protocols.
Tracing the timeline of severe burns makes it super clear why our clinical focus has to shift rapidly. Right after a high-voltage electrical burn, the most common immediate cause of death is cardiac arrest or ventricular fibrillation. Moving into that critical 24 to 36-hour window after a severe thermal burn, hypovolemic shock completely takes over as the absolute primary threat. At the exact same time, between 4 and 24 hours, you've got to be hypervigilant for upper airway edema. Any change in voice or stridor demands early elective intubation. Finally, if the patient survives those first few days, the threat shifts entirely once again. After 5 days, gram-negative sepsis and multi-organ failure become the leading causes of mortality.
Our source text here outlines the critical math you need during that hypovolemic shock window. To get an initial approximation of resuscitation fluid, we rely on the Parkland formula. That's 4 milliliters times body weight in kilos times the percentage of total body surface area burned. But for a more accurate estimation, especially when you're treating kids, the Lund and Browder chart is the absolute standard.
So the crucial point here is understanding how these pathologies actually evolve. High-voltage burns over 1,000 volts cause massive deep tissue damage, leading to full-thickness burns, cataracts, and rhabdomyolysis that results in acute kidney injury and metabolic acidosis. In terms of infection, the dominant bacterial threat completely shifts. Staph aureus is the most common infection in that first week, but Pseudomonas aeruginosa aggressively takes over after 7 days. For surgical management, deep partial thickness burns need tangential excision, topical antimicrobials, and a split-thickness skin graft. But for full-thickness burns that are circumferential and limb-threatening, an emergency eschorotomy is absolutely required to save the limb.
Ward 4. Reconstructive flaps and grafts. Let's shift gears to reconstructive plastics.
You absolutely must be able to carefully contrast the signs of flap failure. Is it an arterial or a venous problem? If it's an arterial inflow obstruction, the tissue is going to be soft, flaccid, pale, and cold. Turgor is decreased, capillary refill is delayed past 2 seconds, and pinprick bleeding is sluggish or absent. However, a venous outflow obstruction looks completely different. The flap will actually be swollen, blue, and initially warm. Turgor is increased, and capillary refill is super rapid, less than a second. Pinprick bleeding will be dark, and oxygen saturation drops below 90%. So remember, a blue, warm, rapid refill flap is a venous crisis, which is almost always caused by a thrombosis.
If a patient comes in with an amputated digit, how you handle that tissue before the surgeon arrives is critical. This exact step-by-step sequence preserves tissue viability for replantation. Step 1. Wrap the amputated part in saline-soaked moist gauze. Never put it directly in water or plain saline. Step 2. Place that wrapped part into a dry, watertight plastic bag. And step 3. Put that plastic bag inside another plastic bag or container filled with ice. Doing it this way prevents direct frostbite to the tissue while maximizing ischemia time.
Success in reconstruction heavily relies on strict geometry and anatomical knowledge. For example, did you know cleft lip is actually the most common facial cleft at 45%, while an isolated cleft palate is less common at 15%. In tissue rearrangement, the strict geometry of a Z-plasty is fascinating. Using a classical angle of exactly 60 degrees gives you a massive 120% gain in tissue length.
For lower limb reconstruction, the reverse sural artery flap is brilliantly based on the vasa nervosum of the sural artery, fed by perineal artery perforators. For the face, a forehead flap remains cosmetically the best option for reconstructing a large nasal defect. Finally, if a skin graft fails, a hematoma is your most common culprit. And if you suspect an infection by group A beta hemolytic streptococcus, that is an absolute contraindication to grafting. Don't do it.
Ward 5, Neurosurgical Signs and Tumors. Welcome to our final ward.
Let's decode these localizing syndromes like a clinical detective. Each triad of symptoms is a clue pointing directly to an anatomical culprit. If a patient presents with anosmia, loss of smell, in one nostril, plus papilledema, this is Foster-Kennedy syndrome, pointing straight to an anterior cranial fossa tumor, like an olfactory groove meningioma. Gerstmann syndrome presents with acalculia, agraphia, left-right disorientation, and finger agnosia, pinpointing a lesion right in the dominant hemisphere. Now, the classic triad of personality change, gait disturbance, and urinary incontinence, that should make you highly suspicious of a frontal lobe glioma. Bitemporal hemianopia, or loss of peripheral vision, directs you to the mid-optic chiasm, which is typically a pituitary macroadenoma. And tumors in the infratentorial space frequently present with multiple cranial nerve palsies. The most vital role? For any trauma patient with a depressed level of consciousness where the Glasgow Coma Scale is an 8 or less, endotracheal intubation is immediately indicated. Furthermore, to accurately assess them neurosurgically and control intracranial pressure, you're often going to need to paralyze and hyperventilate the patient.
Drilling down on diagnostics for our final sprint of facts, the absolute best way to measure intracranial pressure in a comatose patient is via an intraparenchymal catheter. And remember this absolute rule: a lumbar puncture is totally contraindicated when there's a risk of raised intracranial pressure, as it can cause fatal brain herniation. When a CT scan shows a ring-enhancing lesion, you have to differentiate between a brain abscess, a metastasis, or a glioma. A diffusion-weighted MRI is the exact tool you need to decode that difference. Speaking of metastases, lung carcinoma carries the highest risk of cerebral metastases at 40%, followed by breast cancer at 15%. For primary gliomas, management scales with severity. Low-grade tumors get surgical resection, while high-grade tumors require a rigorous combo of resection, radiotherapy, and chemotherapy.
Picture a patient describing the absolute worst headache of their entire life. That's your classic spontaneous subarachnoid hemorrhage, usually from a ruptured berry aneurysm. The steps here? They're sequential and totally non-negotiable. First up, you grab a CT scan without contrast. If it's negative, but your gut says it's a bleed, you move straight to a lumbar puncture. Once you've confirmed it, step 3 is a 4-vessel angiography to find the exact location of that bleed. And finally, the surgical treatment of choice is a craniotomy and clipping of the aneurysm. Oh, and here's a quick, high-yield pearl from the source. Always remember to give nimodipine for prophylaxis against delayed brain ischemia from vasospasm.
Let's differentiate the heavy hitters when it comes to brain tumors. On the left, we've got meningiomas. These are the absolute most common benign supratentorial tumors in adults. They usually present as densely enhancing, space-occupying lesions with a really broad base of attachment right along the convexity of the dura. On histology, you're going to spot those classic passamoma bodies. Contrast that with the right side, astrocytomas. These are the most common intraaxial primary brain tumors, and their most malignant, aggressive variant is glioblastoma multiforme. Structuring it like this makes the benign versus malignant and extraaxial versus intraaxial distinctions crystal clear. Moving down to the neck and endocrine system, we have some very specific high-yield management rules. To diagnose a pheochromocytoma, after you've done the biochemical testing, the absolute best investigation for preoperative localization is an MRI. For parathyroid localization before surgery, a nuclear medicine system EB scan is your go-to test. And here's a massive pharmacological pearl. For a patient dealing with thyroid issues during pregnancy, propylthiouracil is preferred in the first trimester. Why is that? Well, methimycel is the drug of choice later on, but it's completely avoided early on. And radioactive iodine, that is strictly contraindicated throughout the entire pregnancy. No way you can use that. Breast cancer management. The absolutely crucial point here is knowing exactly what to do when you're faced with a case of occult primary carcinoma found in a positive axillary lymph node. Based on our source material, you've got 2 distinct, perfectly acceptable options. Option 1 is a full mastectomy paired up with chemotherapy. Option 2 is definitely less radical surgically, but it requires way more adjuvant therapy. That's an isolated axillary node dissection followed by both radiotherapy and chemotherapy. Laying these 2 pathways out visually like this really helps you weigh the balance between surgical excision and radiation control.
Let's look at hormone therapy for estrogen and progesterone receptor positive tumors. The dividing line here is literally just menopausal status. For premenopausal women, the gold standard treatment to decrease recurrence is tamoxifen. But for postmenopausal women, that recommended therapy completely shifts over to aromatase inhibitors. It's a simple binary rule, but honestly, it is absolutely foundational in breast cancer management. Treating breast cancer during pregnancy obviously adds a massive layer of complexity, with some incredibly strict safety rules for the fetus. First, a mastectomy is generally the preferred surgical option here. Second, chemotherapy can be administered, but absolutely not during the first trimester. You have to wait. And third, radiotherapy is strictly contraindicated in pregnancy. These are firm boundaries you just have to lock into your memory.
Vascular and thoracic issues.
What is the best investigation for suspected mesenteric ischemia? Picture a patient with ischemic heart disease who suddenly develops severe, debilitating abdominal pain. But here's the catch. When you examine their abdomen, the physical findings are completely unremarkable. The pain is entirely out of proportion to the physical exam.
The answer is angiography. As soon as you suspect mesenteric ischemia based on that classic pain out of proportion presentation, your next step is that gold standard test, angiography. Since this is a surgical emergency, you definitely don't stop there. Step 3 is an immediate laparotomy, which leads straight into Step 4, surgical resection of the devascularized bowel segment. Time is tissue here, and this visual sequence reflects that urgency perfectly.
What's really interesting about this is how neatly the angle brachial index, or ABI, categorizes peripheral vascular disease. A totally normal ABI is between 0.9 and 1.3. If that number drops to between 0.5 and 0.7, the patient will typically present with claudication, which is pain when walking. A further drop to 0.3 to 0.4 indicates rest pain, and anything below 0.3, that means imminent necrosis or gangrene. Conversely, an ABI of 1.4 or greater doesn't mean they have super healthy vessels. It actually points to calcified, non-compressible vessels, which you'll often see in diabetes or end-stage renal disease.
Let's contrast two major vascular presentations, acute limb ischemia versus an abdominal aortic aneurysm. On the left, a patient with a history of ischemic heart disease suddenly complains of severe limb pain, pallor, and a pulseless cold limb. That is acute limb ischemia. The immediate management? Heparinization, specifically a therapeutic dose of unfractionated heparin at 5,000 IU. On the right, managing an asymptomatic AAA is all about really careful monitoring. Regular ultrasonographic assessment is key. Early elective open surgical repair is only indicated when the aneurysm exceeds 55 millimeters in diameter, simply because the risk of rupture rises significantly once it gets past 70 millimeters.
Gastrointestinal emergencies.
Let's look at a crucial postoperative safety protocol, vaccination after a splenectomy. These patients need the polyvalent pneumococcal, meningococcal, and hemophilus vaccines. But the timeline is what you really need to focus on here. If it's an elective splenectomy, you administer these vaccines 2 weeks prior to the surgery. But if the patient comes in for an emergency splenectomy, like after a trauma, you must administer them 2 weeks after the surgery. Reading erect abdominal radiographs to differentiate bowel obstructions can be a bit tricky, but the distinctions are actually really clear-cut once you know them. If the obstruction is in the proximal small bowel, specifically the jejunum, you're going to see valvulae connoventas. If it's in the ileum, the aloops will actually appear featureless. But if the obstruction is in the large intestine, you'll be looking for haustral folds. Keep in mind, air fluid levels are best seen in erect radiographs, and they aren't going to show up if the patient is supine. Here is a classic exam pearl, Wrigler's triad, which is completely diagnostic of gallstone ileus. It consists of 3 highly specific findings. First, signs of a small bowel obstruction. Second, pneumobilia, which is air clearly visible in the biliary tree. And third, a radio-opaque shadow in the right lower quadrant representing the actual gallstone that is lodged in the terminal ileum. When you see these 3 things together, you have your diagnosis for sure. For esophageal complaints, you absolutely need to know your gold standard diagnostics. On the left, the most accurate test for diagnosing gastroesophageal reflux disease, or GERD, is 24-hour pH monitoring. On the right, if you suspect achalasia, which often presents with progressive dysphagia to liquids, the gold standard test is manometry. Having these isolated side by side ensures you won't mix them up when it really counts. Dealing with active upper GI bleeding requires a really rapid escalating response. Step 1 is to immediately administer IV fluids alongside antibiotics and vasopressors. Step 2 is an urgent endoscopy. If you find bleeding varices in there, immediate endoscopic band ligation is the preferred treatment, though sclerotherapy is a less preferable alternative. But what if those measures completely fail and the bleeding is massive? That brings us to step 3, where you employ a Sangstock and Blakemore tube for temporary balloon tamponade to control the bleeding.
Let's take a look at inguinal hernias. The absolute best means to differentiate between a direct and an indirect inguinal hernia intraoperatively is their relationship to the deep inferior epigastric vessels. Furthermore, regarding surgical risks, the most commonly damaged nerve during an open anterior approach hernia repair is the ilioinguinal nerve. Visualizing these anatomical relationships is the key to mastering hernia repairs.
Now, the huge takeaway here is the specific weighting of the criteria. Notice how migratory pain, anorexia, and nausea, they only get 1 point each. But look at the signs in labs. Right iliac fossa or RIF tenderness and leukocytosis, those are heavily weighted at 2 points apiece. So a total score of 0 to 4 pretty much rules out acute appendicitis, and you'd need further evaluation like an ultrasound or CT. A 5 to 6 is kind of equivocal, but a 7 to 10, that is strongly predictive of acute appendicitis and moves your patient rapidly down that surgical pathway. Now picture a patient coming in with jaundice, fever, and right hypochondrial pain 3 whole years after a laparoscopic cholecystectomy. Investigations show a filling defect in the common bile duct. Because of that previous surgery, it's a complex case. If an open choledochotomy with T-tube insertion is done, you absolutely must wait precisely 10 days before doing a T-tube cholangiography to confirm the defect. Then comes a major waiting period. You literally have to wait 4 to 6 weeks for the tract to fully mature before you can safely do a kaleidoscopic stone retrieval. It's just a fantastic example of how surgical patients dictate safety. The critical clinical takeaway for non-obstructed colonic cancers is how the exact anatomical location strictly dictates the resection margin. Check this out. A cancer in the right colon gets a standard right hemicolectomy and a primary ileocolic anastomosis. But if that same tumor sits in the transverse colon or the splenic flexure, you have to upgrade that surgery to an extended right hemicolectomy. Moving down the lower GI tract, we have an absolute classic imaging hallmark. The bird beak sign on a barium enema is a golden diagnostic rule for a sigmoid volvulus. Typically, you'll see this in an elderly patient who has a long history of chronic constipation and comes in with a distended abdomen, pain, and vomiting. If there's no sign of gangrene, the go-to management is endoscopic decompression. But if you see any signs of perforation or gangrene, you're looking at an immediate surgical exploration, which often results in a Hartmann's procedure with an end colostomy. Shifting gears to urological trauma and infections, let's start by analyzing the exact timing of hematuria. A major clinical pearl to keep in your back pocket is that the precise moment blood appears during urination acts literally like a diagnostic homing beacon. If it happens right at the start of urination, you're most likely dealing with urethral pathology. If it's at the very end, your focus needs to shift to the bladder neck or the prostate, and if the blood is mixed throughout the entire urinary stream, the pathology is sitting higher up, either in the bladder itself or the upper urinary tract. You absolutely have to memorize these criteria. A CAUTI is not diagnosed on day 1. The catheter has to be in place for more than 2 days. The patient needs a fever greater than 38 degrees Celsius, along with suprapubic or costovertebral pain. And finally, the urine culture has to show growth equal to or greater than 10 to the power of 5 colony-forming units per milliliter. Only when all of those are met do you start management, which means removing the catheter first if it's no longer needed, and then starting targeted antibiotics for 7 to 14 days. When we look at urological trauma, the mechanism of injury basically tells you everything you need to know. If a patient comes in after a straddle injury, say a nasty fall into a bicycle crossbar, gym equipment, or slipping onto a loose manhole cover, you should instantly suspect trauma to the anterior segment of the urethra. Specifically, it's the bulbar urethra that is the most commonly damaged structure in these classic straddle impacts. Look at this stepwise algorithm for managing renal stones. It's a perfect escalation ladder based entirely on size. Tiny stones, 5 millimeters or smaller, just observe and increase fluid intake. Hit 6 to 8 millimeters, and we bring in medical therapy like tamsulosin. Jump to 8 millimeters up to 2 centimeters, and we use extracorporeal shockwave lithotripsy, or ESWL. But once a stone clears that 2.5 centimeter mark, like one of those massive staghorn calculi often caused by Proteus species, the treatment scales up dramatically to percutaneous nephrolithotomy.
Moving right into urological oncology now. Complex staging, anatomical depth, and strict numeric threshold completely dictate massive surgical decisions here. Before we even look at the cancers themselves,
Think about this critical diagnostic scenario. When an older patient walks into your clinic with painless blood in their urine, what is the absolute minimum workup you cannot compromise on?
The answer is always a dual approach, a renal ultrasound scan combined with a flexible cystoscopy. Oh, and a massive procedural note for the exam. To actually see the ureteric openings in the bladder properly during that cystoscopy, the probe has to be advanced in an anterior and superior direction.
Definitely memorize these key factors. A tumor size greater than 4 centimeters is a massive red flag. Extension directly into the renal vein completely alters your surgical approach, sometimes even requiring a cardiac surgeon if it goes up into the great vessels. The presence of secondaries is an obvious one, but really take note of Stuffer syndrome. That's a rare perineoplastic syndrome causing hepatic dysfunction without actual liver metastases, and it's heavily associated with poor outcomes in RCC. What's fascinating here is how the microscopic depth of muscle invasion strictly dictates the surgical fate of the bladder. If it's a T1 tumor invading the submucosa but skipping the muscle, we can use a bladder-sparing turbid followed by chemo or BCG. But the second that tumor hits T2 and actually invades the detrusor muscle, the pathway shifts instantly to a radical cystectomy with a urinary diversion or external beam radiotherapy if the patient just isn't fit.
A digital rectal exam showing a stony, hard, or nodular prostate is your very first physical clue. If you run a PSA and it's over 10 nanograms per milliliter, a transrectal ultrasound, or TRUS, guided biopsy is recommended. If that PSA is over 35, that is highly suggestive of carcinoma. But keep this exam pearl in mind. Definitive staging and diagnosis requires exactly 12 core biopsies taken from 6 different areas using ultrasound or MRI guidance.
Picture a suspected urethral injury. Maybe you see blood at the meatus. The absolute first rule, do not pass a Foley catheter. If there's a complete tear, your first step is to drain the bladder using a suprapubic cystotomy, which is essentially a percutaneous puncture. Then you just have to wait. Let the bruising and perineal hematoma settle down. Once it does, you perform a retrograde urethrogram using water-soluble contrast to map out the stricture. The definitive fix is a delayed anastomotic urethroplasty, usually done 8 to 12 weeks or even up to 6 months after the initial injury.
Now, exactly where that tear happens changes the entire anatomical picture. Ruptures of the membranous urethra are highly associated with pelvic fractures and extraperitoneal bladder ruptures. But if the injury is lower down, in the penile or bulbar urethra, it is all about Buck's fascia. If Buck's fascia stays intact, the urine collects neatly underneath it. But if you have a bulbar tear and Buck's fascia is completely ruptured, that urine extravasates wildly. It pushes into the superficial perineal pouch, travels up the scrotum, the penile shaft, and even up the anterior abdominal wall all the way to the clavicle.
Moving to circumcision. You're likely familiar with the broad indications, ranging from religious reasons to specific medical needs like balanitis erotica obliterans, recurrent UTIs, phimosis, paraphimosis, or genital warts. But the crucial takeaway here is the absolute contraindication, hypospadias. You never perform a circumcision if hypospadias is present because you might desperately need that foreskin later for surgical reconstruction of the urethra.
If a patient presents with a suspicious, painless testicular mass, the workup has to be completely sequential and strict. And listen, we do not biopsy. Step 1 is always an ultrasound. Step 2, you draw blood for tumor markers. Step 3 is a radical inguinal orchiectomy to actually pathologically stage the tumor. And once that's out of the way, step 4 is a full CT scan of the chest, abdomen, and pelvis to complete the clinical staging.
Section 2. Pediatric surgical interventions and congenital issues.
Check out this decision tree for a non-palpable, undescended testis. The very first fork in the road is whether the condition is unilateral or bilateral. For unilateral presentation, you go straight to laparoscopy. If you find blind-ending vessels, that's a norchia. If it's intra-abdominal, you're deciding between a Fowler-Stevens orchiexy or an orchiectomy. But look at the bilateral pathway. You have to start with an HCG stimulation test. If testosterone increases, you know there's testicular tissue hiding somewhere, so you proceed to laparoscopy. If there's no response, that confirms a norchia.
Timing here is absolutely critical. The ideal window for an archaeopexy is during the first year of life. Why? Because right between 1 and 2 years of age, irreversible histological changes start happening in the testis. If the procedure is delayed, complications like atrophy and torsion skyrocket.
along with a 5 to 10-fold increased risk of malignancy, specifically a seminoma. And here's the really harsh clinical reality. Even if you surgically bring that testis down later in life, the elevated malignancy risk remains completely unaffected.
Now, if a young boy comes in with sudden agonizing pain in the groin and lower abdomen with nausea and vomiting, you have to suspect testicular torsion. On exam, you'll feel a thickened, twisted cord, the cremasteric reflex will be absent, and you'll have a negative Prenz sign, meaning elevating the testis doesn't relieve the pain at all. This is a massive emergency. You have a strict 6-hour window from the onset of symptoms to explore surgically. You untwist the cord, wrap it in warm saline to check for viability, and if it pinks up, you fix it to the tunica albuginea at 3 points. If it's black and infarcted, you have to do an orchiectomy.
Let's group some other common pediatric presentations. For hydroceles, the surgical approach totally depends on the sac. A congenital hydrocele needs a herniatomy. An encysted hydrocele of the cord requires excision. For an acquired hydrocele, you're looking at Lord's plication for a thin sac or Jaboulet's repair for a thick one. Then, look at Meckel's diverticulum. The presentation completely flips based on the patient's age. In adults, the most common presentation is intestinal obstruction, but in children, the most common presentation is actually bleeding.
Section 3. Systemic complications and trauma.
Let's hit some highly testable systemic scenarios. If a patient is on total parenteral nutrition, or TPN, the absolute most common electrolyte abnormality is hypophosphatemia. But if they suddenly develop weakness, lassitude, and vomiting while on TPN, you need to think hyponatremia. For transplant patients, cytomegalovirus is the most common infection. For hypomagnesemia, watch for the specific neurological signs, increased tendon reflexes mixed with flaccid paralysis and vertigo. And for fluid resuscitation, specifically in head or spinal trauma, 0.9% normal saline is definitely preferred over Ringer's lactate. When you're dealing with primary blast injuries from explosions, the stats are stark. The most common injury overall, tympanic membrane rupture. But the most common cause of mortality among people who initially survive the blast is a primary lung injury. If a victim doesn't even make it to treatment, the most common immediate cause of death is an air embolism. And if we're looking at intra-abdominal injuries following a blast, the cecum is the most commonly injured organ, typically due to subserosal hemorrhage.
Anatomy can point you straight to the diagnosis here. If you feel surgical emphysema in the cervical region, it strongly indicates a tracheal injury. But if that air is located in the mediastinum, you're likely dealing with an esophageal injury. Also, note that a diabetic patient with air in the gallbladder has an emphysematous gallbladder. That requires an emergency cholecystectomy because the risk of rupture is incredibly high. And just a quick pearl for closures, silk sutures cause the highest tissue reaction, while stainless steel wire causes the absolute least.
Section 4. Orthopedics and High-Yield Clinical Science.
Visualizing ulcer edges is a classic instant diagnostic tool. If you're looking at a rolled edge, think basal cell carcinoma. An everted edge? That points to squamous cell carcinoma. An undermined edge is the classic presentation for a tuberculous ulcer, and a sloping edge is typical of a standard venous ulcer. Knowing these four allows for rapid bedside differentiation.
Let's rapidly run through some orthopedic most commons. The most commonly fractured bone overall is the clavicle, but the most common long bone fracture in an adult is the tibia. In the wrist, the most commonly fractured bone is the scaphoid, while the most commonly dislocated wrist bone is the lunate. Finally, the most common dislocated joint in an adult is the shoulder, but in a child, it's the elbow.
Here is a super easy mental anchor for anatomy, the dude mnemonic. If you ever need to recall the 4 structures in the human body that are exactly 25 centimeters long, just remember dude, duodenum, ureter, descending colon, and esophagus. It's a really elegant way to group these structures mentally.
Referred pain is a huge part of surgical diagnosis, and Kerr's sign is a classic example. When a patient has a splenic injury, the escaping blood irritates the diaphragm. Because the diaphragm shares innervation pathways at the C3 and C4 nerve roots, the brain actually perceives this irritation as pain shifting all the way up to the left shoulder.
Differentiating leg pain is critical. For a deep venous thrombosis, you're checking for Hohmann's sign, which is pain upon dorsiflexion of the foot, and Moses' sign, which is pain when you compress the calf against the tibia. However, if your patient has excruciating pain upon passive extension of the foot, that distinct sign signals compartment syndrome. That is an immediate limb-threatening emergency that requires a fasciotomy.
Let's round this out with a few final highly testable pearls. For plantar warts, cryotherapy is your best treatment.
In the spine, the most common cervical injury occurs right at the C6, C7 level, followed closely by C5, C6. And when you're evaluating trauma in junction zones, specifically the right hypochondrium, remember that laparoscopy is actually more sensitive than a CT scan for picking up those subtle intra-abdominal injuries.
Take a look at how incredibly specific the monitoring pathways are for different blood thinners. This is an absolute must-know. If you have a patient on warfarin, you're checking their PT and INR. But the second you switch to heparin, the whole game changes. Low molecular weight heparin requires a factor X assay, while unfractionated heparin is monitored using the APT. And then you have rivaroxaban, which acts directly as a factor XA inhibitor. Nailing these down means you're never second-guessing yourself when adjusting these high-risk medications.
Now, topical burn treatments carry some seriously snaky hidden dangers. It is definitely not just about slapping on an antimicrobial because you have to anticipate the systemic fallout. If you use silver nitrate, you need to watch closely for hyponatremia and, in rare cases, methemoglobinemia. Silver sulfadiazine is super common, but it carries a very real risk of neutropenia due to neutrophil margination. And mafenate acetate can actually trigger metabolic acidosis by inhibiting carbonic anhydrase. You are treating the burn, sure, but you constantly have to monitor the entire system. Let's hit some rapid-fire operational facts. If your patient is overloaded on heparin, you are grabbing protamine. For benzodiazepine overdose, that's flumazenil. On the equipment side, when you have heat-sensitive surgical instruments, ethylene oxide, or ETO, is the standard go-to. However, hydrogen peroxide gas plasma is gaining a lot of traction as an eco-friendly alternative without the harmful byproducts. Oh, and a highly practical pearl, if you are cleaning up a blood spill known to contain hepatitis B, plain old sodium hypochlorite, which is just bleach, is your absolute best bet because of its intense virucidal properties.
Section 2 covers critical care and metabolism. The biggest takeaway here is the massive difference in neurological consequences if you correct sodium too quickly. You always have to respect the speed limits of metabolic correction. For hyponatremia, do not correct it faster than 0.5 milliequivalents per liter per hour, capping at 12 a day. Rush it, and you risk central pontine myelinolysis. On the flip side, dropping sodium too fast in a hypernatremic patient, again breaking that 12-a-day limit, can cause cerebral edema. The human brain literally cannot handle those rapid fluid shifts. Remember that a surgical patient's metabolic state is incredibly reactive. As a baseline rule, your average patient needs around 30 kilocalories per kilogram per day. If you start them on total parenteral nutrition, you've got to stay alert for early hyperglycemia and even hepatic steatosis if they are on it long term. Pathologies totally dictate the metabolic state too. For instance, an aortic aneurysm disruption will push the body straight into metabolic acidosis. Meanwhile, pyloric stenosis, because of all the stomach acid lost from vomiting, predictably causes metabolic alkalosis. Here is a must-know definition for the ICU, the Rapid Shallow Breathing Index, or RSBI. When you are trying to figure out if a patient is ready to be extubated, this is your mathematical green light. You just divide their respiratory rate by their tidal volume. It's a remarkably simple, elegant calculation that instantly tells you if their respiratory mechanics can hold up on their own. Section 3 moves into orthopedic trauma and surgery. Orthopedics is basically advanced medical carpentry, so knowing your materials is everything. Believe it or not, titanium implants actually have lower fatigue resistance and a higher notch sensitivity than stainless steel. When you are dealing with osteoporotic, poor quality bone, locking plates are your best friend because they provide superior fixation. For a femur neck fracture, cannulated screws are the standard choice. And if you are putting a lag screw into a dynamic hip screw setup, it absolutely has to be central and subchondral to get the best mechanical stability. Think about a patient with a fresh, severe fracture who starts deteriorating in the recovery room. What is the absolute first red flag you are looking for to catch a surgical emergency? It is pain on passive movement. That is your blaring alarm that intracompartmental pressure is climbing dangerously high. It is the earliest and most sensitive sign of compartment syndrome. Way before the pulses disappear or the limb turns incredibly pale, simply stretching those muscles passively will cause pain that is completely out of proportion to the initial injury. Looking at bone healing, it happens in very distinct steps. First, you get this weak, woven bone laid down. Then, during the remodeling phase, much stronger lamellar bone replaces it to bring back full structural integrity. This biological process is exactly why a mixed cancellous and cortical autograft is considered the holy grail of bone grafting.
It naturally delivers all three essential elements you need: osteogenesis, osteoinduction, and osteoconduction. Nailing your anatomical approaches is crucial to avoid iatrogenic damage. In a total knee arthroplasty, the subvastus approach is highly regarded because it preserves the quadriceps mechanism, which really speeds up recovery. Taking a posterior approach to the hip, you are going to split the gluteus maximus and actively detach the short external rotators. And for the upper body, the posterolateral approach to the humerus is picked specifically because it gives you direct access to the radial nerve and the spiral groove, making it much easier to protect.
Section 4 looks at nerve injuries and complications. Here is a quick clinical scenario. You ask a patient to make the classic OK sign with their thumb and index finger, and they physically just can't do it. Which specific nerve is compromised? It's the anterior interosseous nerve. And the really fascinating pearl for your exams here is that this specific motor deficit, losing flexion at the interphalangeal joint of the thumb and the distal interphalangeal joint of the index finger, happens completely without any sensory loss. It is a purely motor issue.
It's wild how specific upper extremity nerve deficits are. If you damage the spinal accessory nerve, the trapezius is paralyzed, so the patient cannot abduct their shoulder past 90 degrees. In supracondylar fractures, the ulnar nerve can take a hit, causing clawing of the fourth and fifth fingers. But remember, the median nerve is actually the most commonly injured nerve in supracondylar humerus fractures overall. And just like the anterior interosseous nerve we just covered, hurting the posterior interosseous nerve leads to wrist and finger extension weakness without any sensory loss at all.
Down in the lower extremity, the surgical approach totally dictates the nerve at risk. The lateral femoral cutaneous nerve is the classic casualty in an anterior hip approach, causing meningeoparesthetica, which is that burning feeling on the outer thigh. But if you are using a lateral approach to the hip and you go just a bit too far proximally, you put the superior gluteal nerve right in the crosshairs, which is going to severely mess with hip abduction. We have to factor in systemic complications from anesthesia and our surgical tools. Succinylcholine comes with a serious risk of hyperkalemia, which is exactly why it is strictly avoided if your patient has major burns or crush injuries. Ketamine is unique since it causes sympathetic stimulation, triggering tachycardia. If you are ever staring down a local anesthetic overdose, your immediate go-to is intravenous lipid emulsion. And lastly, never take a tourniquet for granted. Prolonged tourniquet ischemia causes major muscle breakdown, sending the patient into rhabdomyolysis and acute renal failure.
Before a patient ever sees the inside of an operating room, we have a very strict sequence we have to follow. First, we need to find out exactly what the tumor is, right? We do that with a histological diagnosis, which is usually a biopsy or an FNAC. Then, we find out where it is, we map out any local or distant spread using a contrast CT, MRI, or a PET CT. Once that tumor is mapped, we have to check the patient's engine. We run systemic blood checks like a CBC, renal function, liver function, and electrolytes. We also run cardiopulmonary tests with an ECG and chest imaging just to make absolutely sure they are physically fit for the immense stress of surgery. On top of that, a dedicated nutritional assessment is totally key for their healing process. Finally, this entire strategy is brought together and finalized in an MDT discussion. We clear their anesthetic fitness, and, critically, we obtain informed consent from the patient.
Moving on to Section 2, neoadjuvant and adjuvant therapies, because in oncology, timing is literally everything.
And this brilliantly illustrates how we use that timing. Neoadjuvant therapy happens before the scalpel ever touches the patient. We use it heavily to shrink tumors down to a resectable size. This is a highly standard approach for rectal and esophageal cancers, which often use chemoradiotherapy. We also rely on neoadjuvant approaches for gastric, borderline pancreatic, and bladder cancers, plus selected breast and advanced ovarian cases. Conversely, adjuvant therapy acts like a cleanup crew. It's given after surgery to catch any lingering microscopic disease and prevent recurrence. This is standard protocol for stage 3 colon, rectal, gastric, and pancreatic cancers. It's also the absolute go-to for glioblastomas, differentiated thyroid cancers, which use radioactive iodine, along with ovarian, high-risk endometrial, breast, and many head and neck cancers. Notice how fluid this whole thing is? Cancers like gastric and rectal can actually utilize both, depending entirely on the patient's precise staging.
Section 3, head, neck, and endocrine surgeries. We are exploring the brain, the thyroid, and the airway.
Starting right at the top in the brain, a glioblastoma requires a maximal safe craniotomy and excision, and that has to be followed by a heavy hit of adjuvant radiotherapy and temozolomide. But for a meningioma, complete excision via craniotomy is usually enough. We generally reserve adjuvant radiotherapy only for high-grade or residual cases. Moving down to the thyroid, our surgical approach gets highly specialized. For papillary or follicular cancers, the standard is a total thyroidectomy, with or without a central neck dissection. And we frequently follow that up with radioactive iodine as an adjuvant therapy. Now, medullary thyroid cancer also requires a total thyroidectomy and a central neck dissection, but we actually skip the radioactive iodine here in favor of targeted therapy if it's advanced. Finally, anaplastic thyroid cancer is incredibly aggressive. That's why it's usually unresectable, meaning we rely heavily on palliative chemoradiotherapy rather than standard surgery.
As we examine the oral cavity and tongue, squamous cell carcinomas or SCCs in these areas often require a wide local excision or a hemiglossectomy. Crucially, these are frequently paired with a radical neck dissection just to ensure we clear out those lymph nodes. Neoadjuvant therapy here is really reserved for select advanced cases, while adjuvant radiation with or without chemotherapy is very common. But if the cancer is sitting in the larynx, a total laryngectomy might actually be avoided in advanced stages. We do that by hitting it with neoadjuvant chemoradiation first, followed by adjuvant radiation, which keeps actual surgery as a highly specific backup tool.
Section 4, GI and hepatobiliary. Now, what's really interesting about this next part is the sheer density of high-yield abdominal data we're about to cover.
Traveling down the GI tract, an esophageal tumor, whether it's an SCC or an adenocarcinoma, requires a massive esophagectomy. We're talking procedures like the Ivor-Lewis or McCune, and these rely heavily on neoadjuvant chemoradiotherapy first. Down in the stomach, for an adenocarcinoma, we'd perform a subtotal or total gastrectomy with a very precise D2 lymph node clearance, and that utilizes both neoadjuvant and adjuvant chemotherapy. As we hit the duodenum and pancreas, the famous Whipple procedure, also known as a pancreaticoduodectomy, takes center stage for duodenal adenocarcinoma and tumors right in the head of the pancreas. That's usually bracketed by chemotherapy. However, if that tumor sits in the body or tail of the pancreas, the anatomy shifts, so it simply requires a distal pancreatectomy with or without removing the spleen.
Shifting over to the hepatobiliary organs. For liver hepatocellular carcinoma, or HCC, the standard is a direct hepatic resection, so a right or left hepatectomy. Neoadjuvant is quite rare here, and adjuvant relies heavily on targeted or immunotherapy. For gallbladder carcinoma, we use a radical cholecystectomy, which means we're taking adjacent liver segments and lymph nodes along with it, followed up by adjuvant chemo. Now notice the stark clinical contrast in bile duct treatments. If a cholangiocarcinoma sits in the distal bile duct, we use the Whipple procedure, just exactly like we did with the pancreamic head. But if that tumor sits high up at the hilum, which we call a Klatskin tumor, the approach radically shifts. We actually have to perform a hepatectomy plus a bile duct excision. So it really is all about surgical location.
Going deeper into the lower GI tract, a small bowel adenocarcinoma needs a straightforward segmental bowel resection. In the colon, the exact anatomy dictates the specific hemicolectomy, whether it's right, extended right, left, or a sigmoid colectomy. We completely skip neoadjuvant here, but stage 3 cases definitely get adjuvant chemotherapy. As we reach the rectum, the surgical choice is absolutely critical. An upper rectal tumor allows for a low anterior resection, or LAR, which is great because it preserves the sphincter. But a very low tumor often forces an abdominal perineal resection, or APR, permanently removing the sphincter. Both of these heavily utilize neoadjuvant chemoradiation. Uniquely, anal canal SCCs avoid the knife almost entirely at first. They favor the Nigro protocol chemoradiation, and we reserve an APR only for persistent, stubborn disease.
Section 5, genitourinary and gynecological. Let's look at pelvic surgeries.
Starting with the kidneys, renal cell carcinomas mean a partial or radical nephrectomy, often followed by immunotherapy in selected cases. If we're dealing with urothelial cancer down in the ureter, we perform a specific nephroureterectomy, leaning on adjuvant chemotherapy if it's needed. Down in the bladder, a muscle-invasive transitional cell carcinoma requires a massive, radical cystectomy with a urinary diversion. And you'll see this is almost always prefaced by neoadjuvant chemotherapy to shrink it first. For localized prostate adenocarcinoma, the gold standard is a radical prostatectomy, which is occasionally followed by adjuvant radiation or hormonal therapy. Lastly, for germ cell tumors of the testis, the strict standard is a radical inguinal orchidectomy utilizing adjuvant BEP chemotherapy when indicated, and we completely skip the neoadjuvant phase for those.
Mapping out the gynecological cancers, we see some really clear structural patterns. For epithelial ovarian cancer, surgical staging is a massive undertaking. It requires a total abdominal hysterectomy with bilateral salpingo-oophorectomy, famously known as a TAHBSO, along with an omentectomy. Neoadjuvant chemo is used for advanced stages, and adjuvant is highly standard.
Endometrial carcinoma uses that exact same TAH-BSO base but focuses much more on adjuvant radiation rather than chemo. For early cervix or vulva cancers, the surgeries become highly radical, focusing heavily on local structural control. So we see radical hysterectomies for the cervix and radical vulvectomies with inguinal node clearance for the vulva, bringing in adjuvant radiation as needed.
Section 6. Essential postoperative care. So the crucial point to remember here is,
the patient's journey doesn't just end in the operating room. We immediately have to manage their pain, get them mobilized early, ensure DVT prophylaxis, and strictly monitor their drains and wounds as we transition them from IV fluids back to normal oral feeding. But clinically speaking, the most critical next step happens under the microscope. Once the tissue is out, the final histopathology dictates the ultimate TNM staging. That specific stage is the exact trigger for the adjuvant therapies we discussed earlier. It is literally this final pathology report that determines the patient's long-term survival protocol and the rigor of their lifelong follow-up surveillance.
So the classic presentation of a kidney stone attack is really anchored by that sudden, severe, colicky flank pain. And colicky just means the pain hits in these incredibly sharp, intense waves, right? It's the body frantically trying to squeeze that stone through the ureter. Usually you're going to see this pain radiating straight down to the groin. The patient might also have hematuria, so blood in the urine, and honestly, because the pain is just so overwhelming, it's almost always accompanied by severe nausea and vomiting.
Now, looking at the exact timeline a doctor actually follows, a super clear priority emerges. We treat the patient's stability first, and we treat the stone second. Notice how the very first minute, right through the first hour, is entirely dedicated to checking for red flags. We don't even think about day 2 definitive treatment planning until we are absolutely certain the patient is stable and we've got all our imaging data in hand.
Moving to Section 2, Spotting the Red Flags. Assess stability. This right here is the most critical fork in the road of our whole algorithm.
The absolute first question this algorithm forces us to ask is, are we dealing with a simple obstruction, or is this a dangerous infection? You see, a kidney stone on its own, it's painful for sure, but a stone blocking an infected kidney, that is a life-threatening urological emergency. We basically have to separate the routine cases from the ticking time bombs.
So if you see any of these specific red flags, you're dealing with a potential emergency. We're talking about signs of systemic infection, like fever, rigors, those severe shaking chills, or full-blown sepsis and hypotension. We're also on high alert for functional failures, like anuria, which literally just means zero urine output, acute kidney injury, or anatomical disasters. Think about a bilateral obstruction blocking both kidneys, or a stone in a patient who only has one functioning solitary kidney. Oh, and if their pain and vomiting just cannot be controlled, that is absolutely a red flag too.
The crucial takeaway here is this really stark contrast. A yes to any of those red flags means immediate drainage, but a no? That means we actually have time to breathe and run standard blood and urine tests. This split literally defines the entire treatment pathway. Let's dive into what happens if we're forced down that yes path.
For the yes path, we've got an obstructed, infected system. It's essentially a blocked, pressurized pipe that has to be drained immediately by following 3 super strict steps. Step 1, you hit that infection systemically with IV antibiotics. Step 2, urgent urinary drainage to relieve the pressure and clear out the infected pus. And you've got 2 choices here. Either place a DJ urethric stent from below or pop a percutaneous nephrostomy tube directly into the kidney from the back. Then, step 3, you wait. You only, and I mean literally only, proceed to definitive stone treatment after the infection has completely resolved.
Seriously, I cannot stress this enough. Never, ever try to fragment a stone while the patient is actively septic. Think about it. If you break up a stone inside a highly pressurized, infected kidney, you risk flushing massive amounts of bacteria directly into the bloodstream, and that can be fatal. So the rule is, drain it, cool it down, and fix the stone later.
All right, Section 3, Testing and Imaging, the stable path. Let's jump back to the no pathway and see how we build our baseline data when the patient is completely stable with 0 infection.
We start off by gathering baseline data with a specific battery of standard tests. For the urine, we're doing the urinalyses, microscopy, and hey, if we even slightly suspect an underlying infection, we're sending a culture for sure. Then for the blood work, we pull a complete blood count, check their kidney function with urea and creatinine, and we look at electrolytes, calcium, and uric acid. Why? Because we want to start hunting for the underlying metabolic cause of the stone.
Next up, we use a non-contrast CT-QUB.
This is hands down the absolute best test for acute ureteric stones. It conforms 4 vital pieces of imaging data for us. It gives us the exact size of the stone, its precise location, the degree of obstruction, and whether there's any hydronephrosis, which is just the medical term for the kidney swelling up because of backed up urine.
Moving right along to Section 4, stone size dictates treatment. Once we've got that imaging, the entire game plan relies heavily on some very strict mathematical cutoffs.
These size thresholds neatly divide our treatment plan into 3 crystal clear categories: under 5 millimeters, between 5 and 10 millimeters, and over 10 millimeters. And these aren't just arbitrary numbers we pulled out of thin air. They directly correlate with the statistical likelihood of that stone actually passing on its own.
So for those tiny stones sitting under 5 millimeters, the strategy is just simple observation. You manage the pain with basic NSAID analgesia, stuff like ibuprofen. You tell the patient to maintain normal hydration, and you might add in a drug called tamsulosin. Tamsulosin helps relax the ureter, which is incredibly useful if the stone is located down in the distal part, closer to the bladder. Now, if the stone is in that tricky middle range, say 5 to 10 millimeters, we still try a trial of conservative treatment with tamsulosin. But if it doesn't budge, we have to intervene surgically. And if it's over 10 millimeters, let's be real, it's highly unlikely to pass spontaneously, so we skip the waiting game and move straight to active intervention.
Which brings us to Section 5, definitive surgical procedures. Because what happens when the stone is large, or conservative treatment just flat out fails? Let's translate some of these surgical acronyms.
First up is ESWL. This is your go-to, non-invasive option for smaller to moderate stones. It stands for extracorporeal shockwave lithotripsy. Basically, a machine outside the body fires targeted shockwaves right through the skin to crush the stone into sand. Then, the patient just passes that sand naturally. Pretty wild, right?
Next, we have URS, or ureteroscopy. This is where we go directly into the ureter, particularly if we're dealing with distal stones, or if that ESWL we just talked about failed. We pass a tiny camera up through the bladder, straight into the ureter. Once we spot the stone, we use laser lithotripsy to literally blast it apart, and then we physically extract the pieces.
Finally, we've got PCNL, or percutaneous nephrolithotomy. This is the heavy hitter. It's reserved for massive renal stones over 2 centimeters, or complex staghorn calculi. It's definitely more invasive. We literally create a small tunnel through the patient's back, going directly into the kidney, to break up and vacuum out these huge stones. And if it happens to be a staghorn calculus, one of those massive stones that fills the entire branching system of the kidney, usually made of struvite, then PCNL, followed by complete stone clearance and antibiotics, is the absolute standard of care.
All right, we made it to Section 6, the master summary, the cheat sheet. To absolutely guarantee we haven't missed a single point from our source algorithm, let's put it all together.
This table is the master matrix. It maps every single stone condition directly to its exact clinical action. Just look at how beautifully simple this makes everything. Stone plus sepsis, drained first. Small stone, observe. Persistent ureteric stone, URS or ESWL. Renal stone over 2 centimeters, PCNL. A massive staghorn, PCNL plus full clearance. Now what about the stone's composition? Well, if you find a uric acid stone, you alkalinize the urine to dissolve it. For a struvite stone, you treat the infection and ensure complete clearance. And for recurrent stones, you order a full metabolic workup. Easy.
Listen, if you remember absolutely nothing else from this entire explainer, please remember this undeniable golden rule of urology. Stone plus sepsis equals drain first. It is without a doubt the single most critical, life-saving decision in this entire algorithm.
So, with this clinical flowchart completely decoded, are you ready to confidently navigate the next renal colic emergency? Because right now, you possess the exact step-by-step logic to safely manage literally any stone that comes your way. You know how to assess stability, interpret the imaging, utilize the size thresholds, and select the precise surgical intervention. Thank you so much for joining me to unpack this essential framework. I really hope this structure helps you the next time you're faced with a complex presentation, letting you cut straight through the noise to find the solution. Keep focused, stay curious, and I'll see you in the next explainer.